This is A&P Live Studio. I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced level of healthcare pros. Today, we're going to talk about a condition that often starts with something as simple as swelling, but can unravel into some really lifelong complications. It's a tale of two very different journeys that end up at the exact same diagnosis. So let's start with two stories. First, meet Anjali. She's a healthy 15-year-old, but around puberty, her left leg started to swell gradually and without any pain. There was no injury, no obvious reason for it. Then we have David. He's 62, a melanoma survivor. About 6 months after his cancer treatment, which involved surgery and radiation, his right arm started to swell and it just wouldn't go away. Now, they both present with edema, swelling, but the origin of their condition is where their stories couldn't be more different.
Even though their symptoms look similar on the surface, the reasons behind them are worlds apart. So to really get to the bottom of this, we're going to take a really logical path. We'll kick things off with a refresher on how the body's drainage system is supposed to work, then we'll see what happens when that system fails. We'll unpack the two different routes to failure, dive deep into the cellular chaos that follows, and then finally, we'll look at how we manage this chronic condition. Ready? Let's get into it.
All right. First things first, we have to understand the system at the very heart of this condition, the body's own incredible built-in drainage system.
Think of your lymphatic system as a really sophisticated one-way drainage superhighway. It's absolutely crucial for both fluid balance and your immune health. It all starts at the microscopic level, where fluid and proteins naturally leak out of our blood capillaries into the space between our cells. That's step one, just a normal part of how things work. Then, as you see in step 2, these specialized lymphatic vessels with tiny flap-like openings soak up all that excess fluid. From there, it moves into bigger vessels that have their own muscle and one-way valves to actively pump the fluid, now we call it lymph, forward, always toward the heart. Along the way, this lymph has to pass through filtration stations, our lymph nodes, where immune cells are on patrol. And finally, after all that, the clean fluid is returned right back into our bloodstream. It's a pretty elegant and vital process, right?
So, this entire intricate process really has one primary goal: maintaining a perfect balance in our tissues. The official term for this is interstitial fluid homeostasis. It's all about making sure the fluid environment surrounding our cells has just the right pressure, the right volume, and the right chemical makeup to keep everything functioning perfectly.
So you might be asking, what happens when this finely tuned drainage system gets backed up? Well, that's when normal flow grinds to a halt and becomes stasis, and that is the fundamental failure point we're talking about today.
Now, lymphedema isn't just any kind of swelling. It's a very specific type of mechanical problem, a low-output failure. What this means is that our lymphatic highway just can't keep up with the normal amount of fluid it's supposed to clear out. This creates a traffic jam, a backup. But here's the crucial part. It's not just a backup of water, it's a backup of protein-rich fluid, and that little detail is going to be incredibly important in just a minute.
This backup, this lymph stasis, is the common problem that unites both Anjali and David. But how they each got to this failure point is where their paths totally diverge. So let's break down the two different ways this system can fail.
On one hand, you have primary lymphedema, which is Anjali's situation. This is an intrinsic problem, meaning the genetic blueprints for building the lymphatic system were faulty from the get-go. Maybe the vessels didn't form right, or maybe the nodes are missing. It's pretty rare. On the other hand, we have secondary lymphedema, which is what David has. This is an acquired condition. The lymphatic highway was built perfectly fine, but then something came along and damaged it. This is, by far, the more common form we see.
Let's zoom in on the genetics of primary lymphedema for a second. You don't have to memorize all these gene names, but just look at their jobs. A mutation in a gene like FLT4 messes with how lymphatic cells even grow. A glitch in FOXC2 affects the development of the valves that keep the lymph moving one way. A defect in GATA2 can cause problems with building lymph vessels. It's a powerful reminder of how a single genetic typo can disrupt the construction of this entire complex system.
Now let's flip to the acquired causes, which are much more common. In developed countries, the #1 cause is cancer treatment, exactly what happened to David. Surgery to remove lymph nodes and radiation therapy can really damage that lymphatic highway. Globally, though, a parasitic infection called lymphatic filariasis is the top cause. But we also see lymphedema after major trauma, with chronic vein problems, and even with obesity, which can put so much pressure on the vessels that it essentially squeezes them shut.
And just to give you a sense of how significant this really is, think about breast cancer survivors.
A huge meta-analysis found that almost 22%, that's more than 1 in 5, will develop lymphedema. That's a staggering number, and it really underscores why it's so critical for us as healthcare professionals to understand this condition inside and out. So, whether the problem started with a faulty gene or an external injury, both paths lead to the same destination, lymph stasis. And this is where things get really fascinating at the cellular level, because this stasis kicks off a destructive chain reaction that literally remodels the tissue itself.
And that brings us to a really important clinical question. Why isn't this just simple swelling that you can prop up on a pillow and it goes away? Why does the affected limb so often become chronically hard, firm, and so difficult to treat?
The answer lies in a vicious cycle. Remember that protein-rich fluid we talked about? Well, it doesn't just hang out. It acts like an alarm, triggering a massive inflammatory response. This calls in immune cells, especially a type of T cell, which then pours fuel on the fire by releasing chemicals that promote more inflammation. This chronic, smoldering inflammation then signals the tissue to remodel itself. It tells fibroblasts to lay down tons of hard, fibrous collagen, and it encourages fat cells to grow and multiply. It's this combination of fibrosis and new fat deposition that makes the swelling hard and, over time, irreversible.
Let's get even more specific and look at the key molecular players in this whole mess. Think of TGF-beta1 as the master architect of that hard, fibrous tissue. Then you've got these inflammatory cytokines like interleukins 4, 13, and 6. They not only promote more fibrosis, but they also tell the body to pack more fat into the area. And here's the worst part. These same inflammatory signals actually shut down the body's main repair system for lymphatic vessels, the VEGF-C pathway. So not only is damage actively being done, but the body's ability to fix it is being blocked at the exact same time.
So now that we have a grasp of this cellular chaos, it's pretty clear why managing lymphedema is such a challenge. Let's walk through how we approach it, from figuring out the diagnosis to the mainstays of treatment.
The signs we see clinically are a direct reflection of what's happening underneath. In the early stages, the swelling's all about that excess fluid. It's soft, and if you press on it, it leaves a little pit. That's classic pitting edema. But in the later stages, the picture is dominated by those tissue changes we just talked about. The swelling becomes firm, non-pitting, because of all that fibrosis and fat, and the skin itself can become thick and hard.
Diagnosis really starts at the bedside, with a solid history and physical exam. We look for clues like Stemmer's sign, where you can't pinch the skin on top of the second toe. To actually see the lymphatic system in action and find the blockages, we can use imaging like lymphoscintigraphy. But just as important is ruling out other things. We absolutely have to use tools like ultrasound to make sure we aren't dealing with a blood clot, a DVT, which is a totally different and urgent situation.
Since there's no cure right now, treatment is all about managing the swelling and stopping it from getting worse. The gold standard is something called complete decongestive therapy, or CDT. It has 4 key parts. First, a special kind of gentle massage called manual lymphatic drainage, which helps reroute fluid around the blockages. Second, compression, using multi-layer bandages or garments to keep the fluid from coming back. Third, specific exercises that use the body's own muscle pumps to help move that lymph along. And fourth, and this is so important, is meticulous skincare, because that stagnant fluid makes the limb a prime target for serious infections like cellulitis.
And lymphedema isn't just a problem in one limb. It has ripple effects throughout the body. The integumentary system, our skin, becomes incredibly vulnerable to dangerous infections because immune surveillance is so poor in that stagnant fluid. Our musculoskeletal system takes a hit too. The heaviness of the limb can cause joint problems, muscle weakness, and affect how a person walks. And it's very closely linked with the cardiovascular system because issues with veins can make lymphedema worse and vice versa. It's a great example of how no system in the body truly works in isolation.
Okay, let's bring all these pieces together and do a quick recap of the entire lymphedema story, from a healthy system to a chronic condition.
So the story begins with a normally functioning lymphatic system, keeping everything in balance. Then something causes an initial failure, either a genetic defect from birth or an acquired injury later in life, and this leads to lymph stasis. That stagnant protein-rich fluid then kicks off a destructive pathological cascade of inflammation, fibrosis, and fat deposition that remodels the tissue. And finally, clinical management with CDT is all about manually overcoming that stasis to control symptoms and stop that tissue remodeling in its tracks.
This all leads us to a final and I think really exciting thought for the future. For a long time, we just saw lymphedema as a plumbing problem.
But now we understand it's a complex disease of inflammation and tissue remodeling. So the big question is this. As we get better at developing therapies that target those specific molecular drivers, the inflammation, the fibrosis, could we do more than just manage the swelling? Could we one day actually reverse the tissue damage and restore the limb to a healthier state? That's the hope, and that's exactly where the science is heading.
Stay patho-curious, and I will see you in the next episode. This presentation is for educational purposes only, and is not intended as medical advice, diagnosis, or a substitute for professional healthcare decisions.